but we're here today welcoming you to the launch of the FASD-Informed Practice for the Australian Alcohol and Other Drug Workforce online training module. And I'm here with my colleagues from NOFASD Australia. My name's Melanie Walker. I'm the CEO of the Australian Alcohol and Other Drugs Council, and I will be your tour guide today as we launch this marvellous resource. Before we begin, I'd like to acknowledge the Ngunnawal people, who are the traditional custodians of the land that I'm coming to you from here today. I'm in the ACT, and pay my respects to their elders past, present and emerging. I'd also like to acknowledge the continuing contribution that the Ngunnawal people make to the life of this city and this region. And I'd also like to acknowledge the traditional custodians of the lands that all of you are coming from here today. We've got people joining us from all over Australia, so I'd like to pay respects to all of the traditional custodians on the lands that you're all coming from as well. So today, as I said, we're here to launch the FASD-Informed Practice for the Australian Alcohol and Other Drug Workforce online training module. And this has been a joint project by AADC, the Australian Alcohol and Other Drugs Council, and NOFASD Australia, which is the National Organisation for Fetal Alcohol Spectrum Disorders. So we're very proud to be able to bring this to you today. It's been a long time coming. We've spent about a year working on this. And this is a module that has been adapted from a Canadian resource that was developed for the alcohol and other drug sector workers in Canada. And what we've done is take that resource and work with a really excellent reference group of people who work at the front line of AOD service delivery and experts in FASD from Australia, and adapt that model for our particular context here in Australia. So what we're going to do today is do a bit of a show and tell of the module, and then we're going to have some expert speakers come along and talk you through what they think are the key points. But before we begin, I'd like to also talk about why this is important. And I know we have a very diverse audience here with us today, so I'd just like to recap why this is an important endeavour. So for those of you that don't know this statistic, it's pretty shocking. People with FASD have a life expectancy of 34 years. That's not a mistake, you heard me correctly. People with FASD have a life expectancy of 34. So obviously that's terrible, and it's really important that all of our sectors engage more effectively with people with FASD. What we know is that people with FASD are overrepresented in terms of harms from substance use and dependence, and they're also overrepresented in the criminal justice system, and we're going to talk about that a bit today. This month is FASD Awareness Month, and that's the context in which we're launching this module here for you today. And just recently I was up at Parliament House with our friends from FARE, the Foundation for Alcohol Research and Education, and NACCHO, the National Aboriginal Community Controlled Health Organisation, where they talked about the overrepresentation of people with FASD in the criminal justice system in particular. Now, FARE and NACCHO have led some excellent work in the prevention space in particular, with the Every Moment Matters and the Strongborn campaigns. But what we're going to be talking about today is working with people who already have FASD and how we can enhance those approaches going forward. And this is particularly important given that we know that people with FASD are overrepresented in terms of harms from alcohol and other drug use, and also that crossover between people with alcohol and other drug use issues and participating in the criminal justice system. So in terms of that shocking number that I gave you before about the life expectancy of people with FASD being 34, what do they die of is the question. So most of it is external causes rather than acute effects of FASD itself. So we're talking about suicide, alcohol and other drug-related deaths, and accidents more than anything else. So it's very, very important that we're more effective in engaging people with FASD in alcohol and other drug services in particular. We know that people with FASD learn differently and need different methods of engagement. And we also know that we might need to adapt our practice in the AOD sector to better suit their needs. So that's the context in which we've developed this module. And I'm going to hand over now to my colleague, Sophie Harrington, who is the CEO of NOFASD Australia, and let her talk to you a little bit about why this has been such an important project from NOFASD Australia's perspective. Thanks, Soph.
Thank you, Mel. Hello, everybody, and welcome. I can't believe we've had more than 500 people register today, so welcome and congratulations to everyone involved. We're so delighted to have such a high number in this virtual world that we have today. So NOFASD Australia, you heard Mal mention an extended version of our name is the National Organisation for Fetal Alcohol Spectrum Disorders. So we're Australia's peak body supporting individuals and families living with fetal alcohol spectrum disorder, or perhaps the term you're more familiar with, FASD or FASD, and I'll refer throughout now to FASD. NOFASD promote awareness, prevention, diagnosis, and improved outcomes for those affected by FASD. So we were founded by families over 25 years ago. Families who were at a loss to understand why this brain and body disability received so little support or acknowledgement anyway. And in many cases, medical and other allied health professionals had not heard of the term and didn't know of the disability. Positively, we can fast forward 25 years and FASD has been recognised by the Australian Government Department of Health, Disability and Ageing and the NDIS as an extremely prevalent disability, so affecting nearly 4% of the population based on conservative research estimates published just this year in 2025. So for this reason, over the last decade, the government has invested in strategic plans tied to effective actions. And from this investment, many valuable initiatives have evolved, including the National Helpline, which is operated by NOFASD, world-class diagnostic clinics, and just this month, the establishment of a Centre of Research Excellence, spearheaded by Professor Elizabeth Elliott, one of our panellists here today, and a board member for NOFASD Australia. FASD is often misunderstood and many individuals remain undiagnosed or misdiagnosed, unfortunately. And because of the nature of the disability symptoms and its effects, some population groups are found to have high rates of the disability, which has not previously been recognised. The Australian Alcohol and Other Drugs Prevention and Intervention Workforce for harmful substance use face unrecognised FASD amongst their clients every day. So being alive to the possibility of FASD and recognising what it might look like when supporting clients struggling with harmful substance use really is a critical first step towards improving outcomes. So for that reason, this online programme really is a game changer and an Australian first to target the interplay between FASD and harmful substance use. You may be aware that I am reading from notes today, just going to make that a known fact in case you can hear my paper rustling. I'm human, what can I say? Today's launch is called 9 Reasons to See FASD and to Know FASD, which coincides, as Mel said already, with global awareness raising, which is held every September. We make it a month, and the month is chosen because it's the 9th month and symbolises the 9 months of pregnancy. Awareness and information events are held on International FASD Awareness Day throughout the world. The 9th month, often the 9th day, to symbolise that importance of those 9 months of being alcohol-free during pregnancy. So many Australians remain unaware that the development of a baby can be affected even before the pregnancy is identified, and that there is no safe time or amount or type of alcohol which can be consumed. Thanks to funding received through FARE and the Australian Government Department of Health, Disability and Ageing, we are very proud to launch Australia's first FASD-Informed online training course tailored for the alcohol and other drug sector. We are deeply grateful for the collaboration and sector expertise provided by AADC, Mel and her team, and their expert reference group, whose contributions have helped ensure the course is relevant and impactful for the Australian AOD workforce. Thank you for joining us today in our broad mission to improve outcomes for those impacted by FASD, and especially for this event. For those who may have FASD, this event for those who may have FASD and are currently experiencing drug and alcohol dependence. They need your help, they need our help. Our free helpline operates 365 days a year, offering vital information and support to families, individuals, clinicians, and service providers across Australia. And that helpline number will be shared with you later on, along with some other helpline numbers also. Whether you are seeking guidance, resources, training, or simply to talk to someone, our helpline is there 365 days a year, and our team is there to help. So I would like to thank again Mel and the AADC group for hosting us today. I'd also like to thank Simone McKenry, who I'll be handing over to shortly, who is a project support officer with NOFASD, and who I can honestly say without her hard work over the last many months, this would not be happening today, along with many others. And I also will just give a shout out to Louise Gray, Specialist Advisor for NOFASD, who's also been integrally involved as part of the team. So as the CEO for NOFASD, as someone who had a background in the AOD sector, in out-of-home care, child protection and justice, who didn't know that their eldest biological son was living with FASD until I joined the organisation and did more research and have better understanding, I thank you for being here to help support individuals. Over to you, Simone.
Thanks, Mel and Sophie. I'm just going to share my screen. So, hello everyone. I'm presenting from the lands of the Wurundjeri Woiwurrung people of the Kulin Nation, and I'll be guiding you through the course content of FASD-Informed Practice for the Australian Alcohol and Other Drug Workforce. The course was originally developed by Canada FASD Research Network, or CanFASD. And as mentioned, NOFASD Australia and AADC have partnered to adapt the content to ensure it is relevant for the Australian AOD services. As part of the process, we have worked with a reference group, which James will discuss later in more detail. And the reference group has provided AOD and FASD-specific input, which has helped guide the adaptations. This also included adjusting North American terminology where possible. However, as the material is based on evidence developed by CanFASD, not all these terms could be altered. So this course is a practical, interactive, self-paced and online, designed specifically to guide AOD professionals across Australia. And our aim is to help you understand Fetal Alcohol Spectrum Disorder, or FASD, and provide strategies that can help be applied in your everyday work. By doing so, we hope to enhance engagement and improve outcomes for individuals in your service. FASD, or Fetal Alcohol Spectrum Disorder, is a diagnostic term used to describe impacts on the brain and body of individuals prenatally exposed to alcohol. FASD is a lifelong disability. Individuals with FASD will experience some degree of challenges in their daily living and need support with motor skills, physical health, learning, memory, attention, communication, emotional regulation, and social skills to reach their full potential. Each individual with FASD is unique and has areas of both strengths and challenges. FASD is often referred to as a hidden disability because impacts aren't always immediately visible. Many people living with FASD go undiagnosed or are misdiagnosed, and without the appropriate supports, they may face significant challenges across education, employment, relationships, and within the justice and health systems. The AOD workforce plays a vital role in the prevention, identification, and management of FASD. Individuals living with FASD often face unique challenges that may influence substance use or treatment engagement. It's important for us to recognise how FASD presents and to adapt treatment environments accordingly. Even small adjustments can make a big difference in accessibility, understanding, and overall success in treatment. To support this, the course has been specifically tailored for the AOD workforce, addressing the intersection between FASD and AOD services. This ensures that the content is directly relevant, practical, and immediately applicable to work with your clients. So the course is made up of 6 interactive modules, each designed to build your knowledge and practical skills progressively through a combination of engaging content, real-life examples, and interactive exercises. The modules guide you from foundational concepts to applied strategies. At the core of the module is Understanding the Person, which is an introduction to FASD, providing a clear understanding of its causes, characteristics, and the common challenges experienced by individuals living with FASD. It also provides practical ways to support you in recognising individuals who may potentially have FASD in your service. The course then continues to a module that explores applying a FASD lens to the stages of the treatment process, starting with entry to AOD services. For many people with FASD, just getting through the door can be the hardest part. Barriers like complex eligibility requirements, lengthy forms, or confusing intake processes can really prevent access. This lesson provides examples and ways to accommodate these challenges that include providing support with administrative barriers, such as offering to help fill out forms, providing reminders or step-by-step explanations. Also, reviewing eligibility requirements to make sure services aren't unintentionally excluding people. It then moves into adjustment to treatment practices. Once someone is in a service, the next step is adjusting practices to support the individual. And this might include engaging external supports, involving people like NOFASD Australia, advocates, peer workers, to provide extra support or information, as well as including support people such as family members to provide further information or, if appropriate, attend appointments. Skill building, enhancing skills by breaking down tasks into small achievable steps, setting clear boundaries, structure and consistency. This creates predictability, predictable environments which reduce stress and create safety and trust. Allowing for flexibility, so be open to adapting approaches and understanding that one size doesn't always fit all. Supporting sensory needs, be aware of sensory triggers, reducing distractions or finding environments that reduce sensory overload, such as quiet places. And using repetition and hands-on practice, revisiting and providing lots of opportunities to share information and ensure understanding. Also recognizing that learning is often strengthened by doing. We then move into transition after treatment. This is where many individuals can fall through the gaps, especially those with FASD, and without the right supports, gains made during treatment can be difficult to sustain. This lesson provides information and highlights things to consider in a transition plan, like identifying and building on existing strengths rather than focusing only on challenges, ensuring the plan is created collaboratively with individuals and their support networks, and addressing life circumstances such as family, housing, finances, and community connections, as these all play a role in whether treatment outcomes are sustained. And then we moved into the final stage, which is maintaining and/or re-engaging. The final stage of the process is about maintaining progress and supporting re-engagement if needed. We know that treatment isn't a straight line and setbacks are common. For people with FASD, maintaining progress often requires ongoing and flexible support. So this could include follow-up support like regular check-ins, reminders or booster sessions, or facilitating their community connections and linking them with safe, supportive networks. Co-developing tailored treatment plans that help individuals re-engage easily by making sure future approaches build on what has and hasn't worked in the past. We then move on to further modules that explore enhancing program practices to be FASD-informed and enacting person-first program philosophies. These modules also guide AOD services in creating treatment environments that truly meet the needs of individuals living with FASD. They explore practical ways to enhance programs through FASD education and training, harm reduction, supporting overall wellbeing and ongoing evaluation, while highlighting the importance of person-first approaches by considering cultural and trauma factors and focusing on strengths and interdependence. These modules help ensure services are respectful, supportive, and responsive to each individual's unique needs. I'd like to share 3 simple adjustments that are practical and easy to apply to your everyday practice. A little sneak peek of what you'd expect to gain from completing the course. So the first tip is simplify processes and communication. As I mentioned earlier, many people with FASD struggle with memory, attention, and processing information. Complicated intake forms, lengthy explanations, or too many instructions at once can quickly become overwhelming. By breaking down tasks into smaller steps, using plain language, offering reminders or visual aids, you can make services much more accessible. Even small changes like offering to sit with a person and fill out paperwork or provide individual key points in writing to take home can reduce big barriers. Second tip, provide structure, consistency and predictability. People with FASD often thrive in environments that are clear and consistent. Sudden changes, unclear expectations, or inconsistent boundaries can cause stress and or a disengagement. Setting up predictable routines, explaining what will happen next, and following through on agreements will help build trust and safety. For example, starting each session with a short, "What will we cover today?" outline can anchor the person and make the experience less overwhelming. And finally, focus on strengths and practical skill building. It's important when working with individuals with FASD to focus on what they can do rather than what they can't. People with FASD respond best when their strengths are recognised and built upon. Practical hands-on learning is usually more effective than abstract discussion. This might mean role-playing scenarios, practicing coping strategies step by step, or celebrating small wins to build confidence. When services highlight what's working well and create opportunities for success, clients are more likely to engage and be motivated. So this course also is an opportunity to reflect on how assumptions, stigma, and lack of awareness can unintentionally exclude or disadvantage individuals who are living with FASD. It isn't about starting from scratch or creating separate or new systems. It's about making small adjustments to your practice. So by completing this course, you will build a deeper understanding of what FASD is and how it impacts people accessing AOD services, learn practical, adaptable strategies that reduce barriers to treatment and improve client engagement, develop confidence in recognising and responding to individuals with cognitive and communication challenges, gain a toolkit of evidence-based strategies to add to your everyday practice, as well as receiving a certificate on completion. I strongly encourage you to enrol in the course so you can learn more about FASD and ways you can support individuals in your service. As Sophie mentioned, NOFASD Australia is here to help. You can find information and resources on our website or by calling our helpline listed on the screen. We can provide information and support to individuals with FASD, their families, carers, clinicians, and service providers. So please contact us. Thank you. I hope this has provided you with some insights into what the course has to offer, and I'll hand back over to you, Mel. I'll just stop sharing my screen.
Thanks, Simone. You're a champion. Thank you so much. And just so that everyone knows, we have popped up in the chat some crisis and support contacts, which includes the NOFASD helpline and the link to their website where you can contact them online. We've also included the National Alcohol and Other Drug Hotline, where you can access AOD services around the country, the number for family drug support, which is also a national line that provides support to families supporting someone with an alcohol and other drug problem. And we've also provided some additional support contacts for Lifeline, 1-800-RESPECT and 13-YARN, just in recognition that we are going to be talking about some pretty heavy topics today. I'd also like to acknowledge that today is actually Are You OK Day. So with that in mind, we have provided those crisis and support contacts as well. And we hope that everyone will go gently with themselves and others today as well. So now I'd like to hand over to James Dunne, who is AADC's Policy and Projects Coordinator. And James has been the champion of this module, who's been working very closely with Simone to develop the module in collaboration with our expert reference group. And he's going to tell you all about that and have a bit of a deeper dive into the module and the case studies that are now embedded in the module to help people work through how the principles that Simone has outlined can be, I guess, brought to life in an AOD service delivery context. So thanks, James. Please take it away. And in the meantime, I note that people are starting to punch their questions into the Q&A. Please do that. You can't see them, but we can. And when we get to the panel session, we'll be addressing those for you as well. So James, go your hardest.
Now, hopefully my screen has come up and I'm sharing that and everyone can see. But thank you. I'll get started. So yeah, thanks Mel and thanks Simone for providing some background on the module and giving us a really nice high level overview of the content. So as Mel said, my name's James Dunne and I'm the Projects and Policy and Projects Coordinator here at AADC, and I'm coming to you from the lands of the Pangarang people in Northeast Victoria. So after Simone's high-level overview, I'm going to take us through a bit more of a deep dive into a couple of sections of the module so you can really start to get a sense of the content and how it can inform and shape some of your work. But before I do, I really want to acknowledge the role of the project reference group and the role they've had in shaping the module. We really could not have done it without their support. So when NOFASD first approached AADC to partner on the production of the module, we really wanted to ensure that it reflected the frontline service environment that many of you here today work within, as well as reflect the experience of those who have FASD. So to do this, we put out a call through our membership for people interested in the topic of FASD or who had some experience working with people with possible or diagnosed FASD. And from that, we're able to assemble a really fantastic reference group whose experience we've drawn from in developing the module. So on the screen are all the names of everybody who was part of the reference group and helped shape the module. I think we had almost every state and territory covered, as well as a really nice mix of metropolitan, rural, and remote area service provision, perspectives and experience. And the primary role of the reference group was to develop a set of case studies that illustrated the learning points for each part of the module. And I think those diverse experiences and perspectives in the reference group have helped create a really rounded, realistic set of case studies that hopefully reflect your experience on the ground as well. So I just really want to give that extra thanks to all the reference group members, some of whom are on our panel later today, and I saw a couple of you in the audience as well. Just a big thanks for giving up your time and your busy schedules and helping us bring this module to life. So now I'm going to take us through one of those case studies that the reference group helped us develop to give you a sense of what that looks like and perhaps even get you thinking about some situations in your work or some characteristics of clients that might be in your services. So this case study is the second part of a two-part case study which explores FASD screening and identification. So in the first part of the case study, a service agrees to include a FASD screening question as part of its intake process. And the case study that I'll read out here is when an AOD worker starts to implement that screening question with a client. And it's really important to emphasise here that it's not the role of AOD workers to diagnose FASD. What we're trying to do here is help identify some of the indicators that a person may possibly have FASD. And in lieu of formal diagnosis, which is frequently difficult to access and very costly, thinking about the ways we might be able to adapt our practice to ensure that we're working with the client's strengths and the way that they process information and the way they respond to the world. So our case study. Shane, an intake worker, meets his new client Jackson for his first intake interview. Jackson attends the appointment with his uncle Gary. Jackson is 24 and he spent most of his life in the care of his aunt and uncle. Jackson's dad died when he was 2 and he has a difficult relationship with his mum. He came to the AOD service through a court-ordered diversion after being arrested and charged with possession of a personal use amount of methamphetamine. Through the documents provided by the court, Shane learns that Jackson has been using illicit drugs and drinking alcohol since he was 14 and regularly uses cannabis, methamphetamine and alcohol. He left school at 16 and he began a mechanics apprenticeship. However, he dropped out after a year as he struggled to complete the TAFE coursework. Jackson has attempted to live independently, however, has been evicted from 2 different properties as he has difficulty managing money and often falls behind on rental payments. And he also struggles to keep the properties to a level of cleanliness deemed acceptable by the real estate agents. After each of these evictions, he has returned to live with his aunt and his uncle. Jackson is talkative throughout the intake process, however becomes silent and quickly becomes angry when Shane begins asking about alcohol and whether Jackson's mum and dad consumed alcohol when he was growing up. I don't know if they are drinking. What does my parents' drinking have to do with any of this? Jackson asks angrily. He gets up to leave but sits back down when his uncle explains that Shane is just trying to get to know him and what's going on in his life. Shane apologises for making Jackson upset and validates Jackson's feelings by saying that it's totally normal to feel this way when a stranger is asking personal questions. Shane also apologises for not explaining why he's asking these questions and not asking if it's okay to discuss alcohol in Jackson's family. Shane says that these are questions that he asks every new client and explains that understanding how alcohol is used by family members helps Shane understand what Jackson's childhood was like and how he can best help. Jackson nods and appears to relax and says that it was so long ago he doesn't really remember if his mum or dad drank much when he was living with them. Gary says, "You remember that time that your mum got busted by the booze bus and you and me had to walk home while your auntie went with your mum to the police station? You must have been about 4 or 5, I reckon." Jackson nods. "Oh yeah, you bought me some Maccas on the way home. That was a bloody long walk for a little kid." Shane uses this anecdote to explore Jackson's mum's drinking further. After the intake interview finishes, Shane makes a note in Jackson's file that the 2 of the intake screening questions were positively responded to, and information from the court documents indicates the possibility of FASD. Shane also notes that he'll implement the new FASD screening tool at a later date through observation of Jackson's behaviour, as well as asking Jackson the screening questions outlined in the tool. Shane does this so he can make his own judgment on the possibility of FASD and to understand where he might need to adapt his practice to best support Jackson. So from this case study, there's a few things that we can sort of take away from there. We know about some of Jackson's behaviours. He struggles with schoolwork and the classroom environment, and he has trouble managing money, and he's got a long history of using substances. We also know that he has a difficult family life and has spent most of his life living with his aunt and uncle. The case study also touches on some of the stigma associated with FASD and the challenges about talking about this for both AOD workers as well as for clients. The module goes into a bit further detail around this and how we can sensitively approach the topic and avoid parents, and particularly mums, being blamed for the challenges that clients might be experiencing in their life. And finally, as I emphasised at the start, we get some insight into how Shane might be able to best work with Jackson. We don't know if Jackson definitely has FASD, but what we do know some of the challenges that he faces, and Shane can use this to adapt the way that he works with Jackson and to be able to work to Jackson's strengths. So now that I've finished the case study, I'm going to take us through a little bit of the content in another part of the module to give you some insight into the practices and advice that you can take away and start to apply in your own work. So this is the part of the module that looks at harm reduction, and I want to take a moment here to stop and thank our friends and colleagues at Able and Karma for their help in putting this part of the course together. This is another really important element of the module because harm reduction services and access to harm reduction support is critical for everyone, and there are ways that harm reduction workers can adapt their practices for clients who may have FASD. So the first part of the module looks at the way that the brain-based differences that a person with FASD has might impact on the context of harm reduction or harm reduction practices. And we can see all these on the slide here. I won't go through them in detail, but we can see here that having FASD affects a person's impulsiveness. So they may have greater difficulty saying no to substances, to using substances, including those that they haven't used before. FASD also affects memory. So a person might have barriers recalling how much of a substance is safe for them to use, or being able to recall harm reduction information that they previously learned. FASD also affects judgment. So a person may have difficulty identifying and or avoiding peers who might not appreciate their vulnerability, or have difficulty avoiding high-risk situations where substances might be available. So we can see here that this part of the module takes you through the impact of FASD in the context of harm reduction. So knowing this, what can we do as AOD and harm reduction workers? Well, the module offers some practical tips and advice. This includes that for the individual, FASD-informed harm reduction practices can include repeating training as necessary. So this might be around using naloxone, repeating advice about not using alone, reminding clients around that after periods of abstinence, such as during residential drug treatment, that might lower their tolerance and they need to use much less of their substance. We can also ensure that any training is strength-based and empowers the individual to prioritise their safety and reduction of harms over needing to hide their experience or experiencing shame over a relapse, for example. And we can also understand that harm reduction and harm reduction support for people with FASD might actually require a higher level of involvement from an individual's family members, friends, or external supports, such as an NDIS caseworker, than it might for other clients. And this is because of the challenges that people with FASD experience around memory, judgment, impulsivity, and comprehension. So some of these practices might include connecting family members and friends and external supports to sources of free naloxone or sterile injecting equipment. And where an individual is on an opioid treatment dependence program, ensuring that friends and family and external support understand how these programs work and the sorts of rules that an individual must follow to ensure that they can stay on the program. And of course, we can connect the individual with our local peer-based drug user organisations like AADC and the organisations in the AADC network. And for friends and families, we can also connect them with Family Drug Support and NOFASD Australia. So there's so much more detailed and specific tips in the module, but in essence, this part of the module and the module more generally is around raising our awareness as AOD workers to the possibility that clients might have FASD, and understanding what this means for the way that clients with FASD process information and experience the world, and then adapting our way of working to a way that engages those clients' strengths. And although we've got lots of specific tips and advice within the module, I think it's really, part of this is around raising our awareness and just thinking around the sorts of clients that we have and the challenges that they're facing and the strengths that they have, and using that as a bit of a prompt to reflect on our own practice and think about where we could adapt for those particular clients. So as I said, there's so much more detail in the harm reduction section and all the other topics that Simone covered in that part of her presentation. What I've given here is just a very quick overview of a couple of sections. So from start to finish, the entire course takes about 4 hours to complete, but it is self-paced and you can drop in and out as you have time. Ideally, we'd love everyone to be able to finish the module from start to finish, but we are all busy and we know that the AOD sector is also very diverse and we all have different roles. So some of the sections are going to have more relevance than others. And I think even if you're able to complete the first few sections of the module and learn more about what FASD is and how it affects people and their strengths and their challenges, and then skip to the practice sections that are most relevant to you, I think there is still lots that you can take away that will be likely to improve your ability to work with clients who may have FASD or who have been diagnosed with FASD. So after the session today, we'll email everyone who's registered with a link to the module with a couple of resources so that you can start working your way through. If you happen to register after about 11 o'clock this morning, you might not be included in that list, but you can use the contact@aadc.org.au email address and just get in touch with us that way, and we'll send you a link separately. Okay, back to you, Mel. Thank you.
Thanks, James. That's awesome. And I think, what we were trying to provide to everyone today is a bit of a show and tell, bit of a taste of what's in the module. There's a lot more in it than what we've been able to show you today, but I think that gives you a bit of a sense of it. And while we have developed this module with the alcohol and other drug sector workers in mind, I think you can see from what we're presenting that it also has relevance in a range of other contexts, homelessness services, disability services, women's sector services. There's stuff that everyone can take away from this module, and that's why it has been designed for you to be able to select the parts that are most relevant to you if you don't need to actually do all of it. I mean, as James said, we would love everyone to do all of it, but you can actually go in and pick and choose the parts that are most relevant to you. And it was particularly important given the absence of particular training available to the AOD sector in Australia at the moment. And again, I'd just like to reiterate those big thanks to the reference group that helped us work on adapting the Canadian module. There was no resourcing to support their involvement in that. Everyone has done this out of the goodness of their heart and because they see a great need for this training in the Australian context. So thank you again for taking time out from your very, very busy day jobs to help us provide this module. So what we're going to do now is go into discussion panel mode, and I will ask our discussion panelists, who include some of the people you've already met and some interesting others, to take your yourselves off mute and put your cameras on now so I can introduce you. So obviously everyone has already met Sophie. Give everyone a wave, Sophie. Sophie is the CEO of NOFASD Australia. You've also already met Simone McKenry, who is the Project Support Officer at NOFASD Australia, who did the lion's share of the work on this module from their end. You've also just met James, who is the Policy and Projects Coordinator at AADC, who was the lead on this project from our end. And I'm also going to introduce a few other people to you. There is Professor Elizabeth Elliott. Now, Liz is a bit of a guru in FASD in Australia and is our clinical brain for this part of the session. Liz wears a number of hats. She works at the University of Sydney. She's also involved with FASD Hub. She's also involved with Children's Hospital. Liz, I'll let you talk a bit more about the various hats that you wear, but we're very, very pleased that you're able to come and join us for this today. I'd also like to introduce Stephanie Holmes. Stephanie is the Executive Officer of the Association of Alcohol and Other Drug Agencies in the Northern Territory, which is the peak body for AOD sector services in the NT and one of AADC's member organisations. Give everyone a wave, Steph. That's Steph. We also have Sam Raven, who is the Senior Policy and Project Officer with the South Australian Network of Drug and Alcohol Services. Sam, give everyone a wave. Sandus is our member organisation in South Australia, and Sam has been leading some work in South Australia in collaboration with NOFASD Australia, where they've already sort of got ahead of the game in terms of working with AOD sector services to upskill them in this area. So what I'm going to do firstly, before we go to questions from the audience, is just let each of the panelists talk to you a little bit about the experience that they bring to the panel and the lens that they bring, and also just give you guys an opportunity to highlight what you think are the key points from the presentations we've had so far and some of the key issues that you think will be of relevance to the audience. So we might start with you, Soph, just because you helped us kick the thing off to start with. What do you think about what we've done with this module, and what do you think are some of the key takeaways for people in that context?
Thanks, Mel, and thanks, Simone and James. Great presentations and really great to step through, having behind the scenes worked on some of the modules in terms of as a participant as opposed to generating the modules. It's great to see them explained to the wider listeners today. And I have to say, this is something that NOFASD and I stand on the shoulder of giants who have been in this organisation for many, many decades. And I know that educating the AOD workforce is something that is a huge space of need. Everybody has such busy jobs. And when we hear from families and individuals affected by prenatal alcohol exposure or who have a FASD diagnosis, the constant rhetoric is people don't understand. We go for services, we go for help, but it doesn't matter what sector we're in, it's really hard to get the right supports for us and the tailored supports. And there's many individuals out there who, as has already been identified, who may be living with FASD, but it is undiagnosed. And they may appear in services and they may be committed and absolutely want to engage and go through the treatment stages. But then unfortunately find themselves back in the space of that revolving door of not being able to get the right supports because, we don't know what the right supports are if we don't know who we're working with and what that potential might need to be. So I'm delighted that this course is about to be released. I'm delighted it's out there and now our stakeholders can start to really access, a FASD-informed AOD workforce. So many highlights and takeaways for me. Who would you like me to pass on to next, Mel?
Thanks, Soph. I think we might go to Steph. Steph, you've been up there in the NT on the front lines, and I know you have a really strong interest in this area. Do you want to tell people a little bit about your background and what you think some of the key takeaways in relation to the module are?
Yeah, sure, Mel. Hi, everyone. Good afternoon. I'm Steph Holmes. I'm the executive of Ardent, which is the peak body for alcohol and other drug services in the Northern Territory. So thank you for having me. Our role is to support and strengthen the workforce and along with advocating for evidence-based policies and, ensuring people and families and member services impacted by alcohol and other drugs receive the support they need. I'm also here on the panel as a mum of a daughter with FASD. So this is very real and personal for me. And I know firsthand the challenges families face navigating systems that don't always understand FASD and the difference it makes when frontline workers have the right, knowledge and approach. I think, Mel, that's, these new modules are so important. They give, the workforce practical tools to respond with understanding and compassion and confidence. But they also, I want to acknowledge the incredible work that's gone into creating these behind the scenes as well. So thank you. It's a big step forward, I think, these modules in harm reduction, building capacity, and, helping, particularly in the Territory, as we know, there's a lot of undiagnosis of FASD, and making, sure families like mine feel seen and supported. That's what it's about. So thank you.
Thanks, Steph. And I really want to acknowledge the lived experience that we have here on the panel today and how much that adds, I think, to this conversation as well. So thank you, Sophie and Steph, for sharing that element of your expertise as well. Liz, I'm going to come to you as the clinician on the panel. What would you like the AOD workforce to take away from this module? And what do you think are the key issues you'd like to highlight from a clinician's perspective?
Thanks, Mel, and hello, everyone. As Mel said, I'm a paediatrician from Sydney, and I lead the Fetal Alcohol Spectrum Disorder Assessment Service in New South Wales. So I see children at the very beginning of their journey with fetal alcohol spectrum disorder. And reflecting on the resources that we've launched today, I'd like to make just 3 points from a clinician's point of view. First is that every person with fetal alcohol spectrum disorder is different. They have different strengths, different challenges, and these may change over time. But all people living with fetal alcohol spectrum disorder will feel its lifelong impact. The second issue is that fetal alcohol spectrum disorder, as we know, results from a brain injury due to prenatal alcohol exposure. And this is what explains all the challenges that we've heard Simone talk about today. And these challenges will impact engagement and sustainment in treatment as well. I suppose an additional point from the medical point of view is to acknowledge that people with fetal alcohol spectrum disorder may also have inherited genes that give them an increased risk of alcohol and drug use and addiction and dependency. And the final point is that if you work in the alcohol and other drug sector, you will see people with fetal alcohol spectrum disorder. You will see people who are undiagnosed. And I think it's just important for all of us to think about this as a possible diagnosis and as a potential reason for people developing alcohol and drug use disorders. And really that's why it really highlights the importance of these resources, as you said, Mel, not only for the alcohol and drug sector, but of course anyone who engages in education, justice, health, disability.
And I think that's it. Thanks, Liz. And as James mentioned, these resources aren't meant to replace assessment and diagnosis of FASD. It's really just about raising awareness that people that you're working with, even if they don't necessarily have a formal diagnosis of FASD, may be living with FASD without that formal diagnosis. And referral is one element of what we're considering, but we're also considering the adaptations that you can do in your daily practice, even if you just suspect that someone might have FASD but don't have that formal diagnosis. So Sam, I might throw to you next because Sanders has been working quite closely with your member organisations in South Australia around what this looks like on the front line and what they're experiencing in AOD services there. Do you want to talk a little bit about that and what you think are the key elements of this training module based on what you've learnt from those conversations and that work?
Yeah, sure. Thanks, Mel. Sanders is the peak body for drug and alcohol services in South Australia. And so, we do a lot of work with our roughly 35 member organisations. And a couple of years ago now, we sort of moved forward with developing a partnership with NOFASD Australia to develop some workshops for this very reason, this kind of acknowledgement that our services are seeing people with either diagnosed or undiagnosed FASD. And I have to say, just from a personal point of view, that it's been a real privilege to work, with NOFASD Australia and then on this particular project as well, because I've just learnt so much. I've worked in the AOD sector probably more years than I'd like to admit, but I just learnt so much around, particularly from the people with lived experience who are often just so generous with their time and sharing their stories. And even just as we heard the case study there that James highlighted, I heard lots of stories like that about, experience of working with AOD services. And I was bringing to mind sort of previous clients that I'd worked with and like, oh yeah, that made sense. And oh yeah, so there was lots of light bulbs going off around, some of those clients that we encounter that are a bit tricky, that often sort of get labelled as difficult or complex or, all these sorts of things that we struggle to work. And, our tried and true methods and approaches and models of care don't quite seem to fit or, we don't quite seem to have the same progress. And so, and I was hearing those stories again and again from drug and alcohol services as well, people who are working on the front lines. And so, it's been just such a privilege to kind of recognise that, and not to say that, we don't know what we're doing or we've been doing anything wrong, but just acknowledging that even with all our evidence-based and good intentions, there's still this other piece that we've got to learn about in terms of how we can work with people with FASD. So as we mentioned, it's not about diagnosis necessarily, but starting to recognise some of those things and some of those, things that might be telling us that there's something else going on here, and really practical ways of just adjusting our practice, thinking about our models of care and how we can be more flexible in that, thinking about how we can support these people within our services to get better outcomes. I think it's just been such a privilege to work on this project. I've just learnt so much, and seeing those light bulbs go off for other people in the sector has been really gratifying as well.
Thanks, Sam. Now, Simone, I'm coming to you next. Just riffing off what Sam was just talking about, what do you think are some of the key take-homes in terms of how you would adapt your approach to someone in an AOD context who you now, having thought about it, might have FASD? What are some of the really practical things that you would do in terms of engaging with them that are a little bit different to how you would go with your mainstream clients?
I think mainly sort of reframing your thinking about and your perceptions about that person and what they might be presenting, and you're sort of might be reading it as lazy or non-compliant or something like that, and just reframing that and thinking about the brain-based issues that might be going on, and adjusting your expectations accordingly. I think is really sort of the first step. I think it's really important. But just simple sort of things like communication and just breaking down tasks and language, just so it just makes the expectations clear and that just gives them a little bit more support, I suppose, which, everyone can benefit from. I don't think it's, just providing a bit of information in different ways can help everyone, I think. So, yeah, so I think that'd be probably a couple of the things. I mean, there's so many of them in the course.
Thanks, Simone. James, I'm going to come to you in a sec, but Sam, I just want to put a pin in something because I'm going to come back to you in a minute. I want you to think about the points around memory and some of the examples that we've talked about how that plays out in the AOD sector in terms of working group settings in particular. So if you can take that one on notice while I go over to James. James, you worked very closely with the reference group in developing the case studies in particular, and you did highlight in particular the harm reduction one as part of your presentation. Can you just take us through perhaps what some of the other case studies in the module include and what some of the key take-homes are for you from that?
So there's 6 case studies in all. So there's one I presented on about screening and identification. There's a couple around accessing services and referring off to external referrals to other support services and considering that, about maintaining engagement and re-engagement after a person might leave the service. There is a specific one about harm reduction, and there's one about trauma-informed care and responses around that, the links between FASD and trauma. I think that was the 6. But I think the really key thing, or the thing that jumps out to me in reading those case studies is, and everyone's mentioned this before, It looks different for FASD might look different for every person that you encounter. Some will have strengths in some areas, others will have challenges in other areas. But I think the point of the module is that awareness raising and just considering the possibility of that, and then working with the client about what their strengths are and adapting the practice. Perhaps it is things around, smaller bits of information at regular intervals. Perhaps it is written information versus, long discussions. Maybe it's a quieter space rather than an open area. It's just kind of it's considering those factors in the different clients that you're working with and having that flexibility to, approach everybody as individuals, but with that FASD informed lens.
Thanks, James. Sam, do you want to add to that in terms of the memory stuff that we flagged?
Yeah, so I think memory was a really key one. And I think in drug and alcohol, the idea that people who use drugs and alcohol may have memory problems is not a new thing. So we already have a lot of strategies that we use with our clients in drug and alcohol, with our people that we work with. But I think from when you're using a FASD lens, if you understand a powerful thing that someone in lived experience said to me through this process with it's if someone you're working with is not doing something, it's not because they won't do it, it's because they can't do it. And so changing that thinking around some of that frustration. So it's just from a basic point of view, sometimes it's about reminders for appointments and just turning up. How can we better facilitate that and help them with reminders? When you're talking in a group context, as you mentioned, it's often around group norms and rules that, at the beginning of a group, we might state, well, here are all the rules and here are all the expectations of behaviour. But then, kind of providing regular reminders, because they're not always going to remember that, oh, I'm not supposed to do that, or that's not within the group norms. So kind of providing those regular reminders in, plain language, rather than signing a sort of code of conduct form at the beginning and then popping it away and never, going back again. Remembering that some of the CBT approaches that we often use in group settings might need to be adjusted when you're working with people with memory difficulties. CBT often sort of involves people going away and doing work outside of the group or outside of an appointment, and how can we support that happening? And often the best way of supporting that happening, if we can, is to involve family and other kind of key supports in that person's life. Of course, that's sometimes tricky and sometimes not appropriate, but I think the more that we can bring in family and supportive loved ones into that process, the more likely we're going to get sort of outcomes around that. And I guess that needs to sort of continue post, discharge. After we finish working with someone, how can we ensure that those supports are still around, either within the capacity of our own service or by making referrals to other services, or by working with, again, those family members to make sure that those reminders and that continual sort of repetition, routine, that sort of stuff can continue post-treatment.
I think those are really practical tips that people working in the front line will really appreciate. And I think you've touched too, Sam, on another place that I wanted to go. So that's a beautiful segue that we didn't even line up. So thank you, which is about through care and transition to community, and how you can work with other services and workers to facilitate that transition. And for mine, I'm about to disclose my own lived experience in this space. I also have a family member in my extended family who has FASD and a history of contact with the criminal justice system. And for us, one of the frustrating things has been working with the probation and parole space. Long story short, our young man can't remember appointments to save his life, and it goes to what you said about intention. He doesn't deliberately not turn up for appointments. It's just that he will agree to attending appointments, and then the minute he walks out of that room, that appointment time has gone. And so breaching probation and parole has been a huge issue, because he won't remember that he's supposed to go to an appointment, but as well won't explain that to someone. He will just agree to do something, but then will completely forget about it. And unless someone in the family or a disability support worker or someone working with him is aware of those appointments, there's no way he's ever going to get to those appointments. So I think that goes to that issue around through care and transition to community, and also the housing space. And I know that in the AOD sector in particular, that issue of being able to transition people from residential programs in particular into stable housing is a huge issue. And when we're talking about people in the FASD space, providing appropriate housing transition points that provide support to people who need that in the community is another big thing. I know we do have a big audience in the juvenile justice and corrections space online today. So I'd be really interested in some of the panelists' thoughts around how we facilitate those transitions, whether it's from a custodial context into community or whether it's from an AOD residential rehab context into community. It kind of looks the same. And what can we be doing to try and assist those transitions? And what do we need in terms of housing options that meet the needs of this community? Sophie, I'm going to come to you because I know NOFASD has been doing a lot of work in WA in particular, in the Banksia Hill context. Do you want to just talk us through a little bit of what that's looked like, both in terms of your work with custodial officers in upskilling them around working with people with FASD, but also what that looks like in terms of the challenges around transitional housing?
Yeah, sure, Mel, thank you. From a perspective of being involved in the WA justice system, that's been working predominantly in the youth justice space. So for all new officers that come through the academy in WA, they undergo FASD information and training sessions, and that looks very much around really breaking down the stigma and actually bringing out into the conversation what FASD may look like and identifying FASD can be amongst all communities, and the propensity for people being involved in the justice system due to the brain-based disability that someone may be living with. And then the sessions move forward to really looking at strategies and relating those back to the environment that the officers may be working in. So we found that has had quite a significant impact in terms of some of the basic things, some of the things that have already been mentioned, but when we're talking about really breaking down steps and in a justice environment, when somebody actually is asked to do something and it's an order and it's something that needs to be complied with, really helping officers to understand that somebody may need a longer processing time, that it may take, it may be those words that Sam said before, it's not something somebody won't do something, it's that they can't do something. And I think really having that understanding around a brain-based difference makes a world of difference in terms of for all sectors, but particularly in the sector that we're talking about right now, is really the burnout that can happen for staff because of that constant frustration of people not sort of following instruction or compliance. From the housing perspective, Mel, as you know, and as we've talked in many sectors as well, really being able to provide the supports and that transition through care is crucial. If I was to refer to my own lived experience scenario of a 19-year-old who lives with FASD but is able to manage to live in accommodation and to maintain work, that's only because there are so many structures and supports in place around financial literacy, financial support, bills and paying rent on time and all those kind of aspects are all absolutely crucial. And the NDIS comes in and plays a part in that when someone has a diagnosis and is able to access those supports. But still there's much, much more work to be done to really educate all of those services and why that transitional support is required.
Thanks, Soph. And you've touched on an important point there around access to the NDIS. And obviously, while we can adapt our practice in AOD sector contexts to work more effectively with people with FASD while they're in our services, there's an issue around needing to be able to refer people for assessment and diagnosis to open that door to access to the NDIS, and ensuring that the NDIS is able to offer accommodation options that are accessible, particularly to our people if they have concurrent contact with the criminal justice system, which sometimes excludes them from accessing those services. So I'm just going to put a pin in that one because I know there are some NDIS people on the line, and I just want that to be something that they're considering in this context as well. But I'm going to go now that we've clocked 2 o'clock. I'm going to throw into some questions that we have online. And Liz, I can see that you're in the midst of answering a question here around the incidence rate. So Sophie and Liz, I'm going to throw to both of you on this one. We've got a question from someone around your introductory comments, Soph, around the incidence of FASD in Australia. Liz and Sophie, are you able to talk to that and where that reference is?
Well, I'll link straight to Liz because I was referencing nearly 4%. And thanks to Liz and many researchers, she can tell you a little bit more information about that recent research.
Thanks, Sophie. Yes, look, we used a lot of information that's been published about alcohol use in pregnancy and the rates of its use in Australia. And we estimated that around 3.6%, that's nearly 4 per 100 people in the general population could have fetal alcohol spectrum disorder. So that would mean one child in every classroom. Now that's in the general population, certain high-risk groups, so we would expect much higher rates in children in foster care, children in the juvenile justice system, where we know that it's up to 1 in 3 in Banksia Hill Detention Centre in Perth, and also children in some remote communities where there's been a lot of historic trauma, current disadvantage and long-term alcohol use. So in one study we did in remote Western Australian communities, we found that 1 in 5 primary school age children had a diagnosis of fetal alcohol spectrum disorder. But the bottom line is it can occur whenever there is alcohol use in pregnancy. It doesn't discriminate by socioeconomic group or ethnicity or aboriginality. And I think we just need to all be aware of the fact that it can occur more commonly than a whole lot of other conditions that we see talked about very frequently, such as autism or cerebral palsy, etc.
Thanks, Liz. And so if I am going to throw to you to just elaborate on Liz's comments there around incidents, particularly around those criminal justice contexts, because while there hasn't been a lot of research done into prevalence in the AOD context, we can come to some conclusions because of the crossover in those communities. Liz has already mentioned Banksia Hill. Do you want to talk about your experiences with Banksia Hill and Unit 18 in particular a little bit more? Because I think that's probably instructive in terms of prevalence in particular settings.
Yeah, I for confidentiality reasons, Mel, I can't go into too much detail about some of the work in Unit 18. But certainly in Banksia Hill, the study that Liz and many other researchers were involved in, which was released back in 2018, highlighted 36% of the cohort with FASD at that time, and a total population of 89% that would have had severe impairment in at least one brain domain. So, you know, we've got to look at those statistics and really think what that looks like. More recently in Queensland, whilst not through an in-depth research study, they're talking about percentages around at least 15% of the population in youth justice. And that's sort of more current information as well as we speak at this time. What we do know is that people are 19 times more likely to be involved in the justice system if they've been with FASD.
And given what we also know about FASD and substance use, so I'm just looking at some other of NOFASD Australia's work over here, approximately 46% of adults with FASD experience AOD-related harms, and across the lifespan they can be up to more than 20 times more likely to develop substance use disorders. So that goes to the sort of prevalence that we're probably looking at in the cohort that's accessing AOD treatment. And when you take into account diversion programs in particular, so people being diverted from the criminal justice system into AOD services, we can see that those prevalence rates are going to be quite high. I've just got a couple of housekeeping questions. Simone, I might pull you in for these ones. So, just because I've asked you a few things, Sophie, you could equally answer these ones, but I'm going to Simone. So, Simone, is the NOFASD helpline a 24-hour service? And are we able to access the course online from New Zealand?
Okay, so we're not a 24-hour service, but we're a 7-day a week, and you know, probably 7 till 7 most days. So we're accessible every day of the year. As far as accessibility of the course outside of Australia, yes, that is possible, but just keep in mind that it is being sort of directed towards Australian audiences. So yes, you can access it by all means.
Excellent. That is good news, Simone. Sophie, I am going to throw to you for this one because I just want you to elaborate on a helpful tip that one of our audience members, Angeline, has put in here, the responsibility of helping with whiteboards can provide wins and help with visual memory reminders for someone with FASD to know what is next every day. So I think that's a really good tip across a range of contexts. Do you or Simone just want to elaborate on the use of whiteboards and memory aids?
Yeah, happy to start. And hi, Ange. And I saw Jessica's also put in a comment as well. So hi to you both. Ange and I often co-present, and likewise with Jessica. With the whiteboards, absolutely. I know Ange and I have had these conversations in the past. That visual and actually having messaging that stays there, it reduces anxiety for people. It means that you commit things to memory, more long-term memory, when there are issues around working memory and short-term memory. So having the visuals of any kind, and whiteboards are fantastic as a support strategy for sure. I've forgotten what your second question was, Mel, if there was a second question.
No, just in terms of whiteboards and visual aids, and there were some examples, I think, Simone, it was you when we were talking in the reference group around how that might work in a sort of AOD resi setting as well. So if I might let you off the hook and let Simone just elaborate on some of those practical techniques.
Yeah, I think just by being able to provide both visual and verbal sort of backs it up and provides independence as well, a bit of independence, because if they've got something to check in with, like a visual, they can sort of reduce having to ask people again and again and feel embarrassed by that, or feel sort of, you know, not as good as their peers or whatever. But also, you know, visuals can also, can't think of the other one I was going to say, I just lost it. But yeah, just providing lots of different ways of listening and seeing things, I think really supports them, individuals in the community and in AOD services. Yeah.
I just want to go to some more questions, and please everyone keep punching them in, we are getting to them. There's questions and comments in here, and I think there's a really good comment from Jess in relation to the AOD space. Jess says, I find I cannot make significant changes to my habits and behaviours without someone with me. Health has been a significant issue and I need body doubling often. Soph, can you just elaborate on what that looks like in different contexts? And then Simone, I might get you to riff off that a little bit as well, because I think it's an important point here, and it goes to the stuff we were talking about earlier as well, about the importance of NDIS access and enabling that sort of support to facilitate transition to community, because we can do the best we can in an AOD context, but we're not going to be able to be with people out in the community necessarily providing the level of support that they need without being able to link to disability support services. So Sophie and Simone, in the first instance, do you want to speak to what that looks like in practical terms and how disability services come in there?
Yeah, I'd love for Jessica to be able to have the opportunity to speak for herself, just because she's the most wonderfully articulate human I know, I think, who can so easily articulate how she feels and what her experience looks like. But in lieu of that, I will say having, you know, the prefrontal cortex has been one of the key areas that's often impacted by prenatal alcohol exposure, and the impact on executive function, and being able to plan and step through and utilise working memory. Being able to have somebody alongside who can help, and I know Jessica refers to that someone like a PA, it's actually being able to help with all of those necessary steps that are extra pressures on the executive function. You know, it's an integral part and a crucial part of support that individuals living with FASD really require. Support people funded through NDIS and other opportunities are crucial. And people who have good executive function to be able to support, to step through and help an individual with FASD. And it's often assumed that somebody who lives with FASD has a low IQ or has an intellectual disability, but actually 2/3 of people don't, and can actually be what some may term as high functioning. I know that's not often a term that's recognised or preferred, but can often really articulate and express and be seen to know what their needs are or be able to step through because they have really good verbal skills. So having a support person is really important. If I was to use our son who isn't as impacted by prenatal alcohol exposure as many can be, for him even to fill out a form, even though he can read age appropriately, he can understand content of the form, the sheer overload of having a number of different questions in a document means that I may have to sit alongside him. And whilst I may not contribute greatly to his processes and stepping through, just having someone there to bounce the question off can actually help him to work through that process. So that's one example.
Thanks, Sophie. Simone, would you like to add to that?
I just want to, just bring to everyone's attention that it's not just a brain-based condition, and there are a lot of physical conditions that are associated with FASD, in fact 428 of them. So it's really important to also understand that there may be some physical and things that are impacting a person as well. They're 5 times more likely to have congenital heart defects. There's also, joint issues, vision, hearing issues, lots of different things that can impact an individual's FASD. So it's important to consider those things, and certainly in the community they can be supported with disability support workers to help around those supports as well.
Excellent, thanks, Simone. Liz, you're up for the next question, I think. In the training, is there clarification or overview of diagnosis of FASD, how and with who, etc.? So that goes to that issue of knowing when to refer someone and how that works. And I know that Sophie would be keen to point out that we have put up the helpline for NOFASD Australia, and you can contact NOFASD Australia to try and hook you up in terms of diagnosis, but we also know that there is a chronic shortage of people with the expertise to be able to do this, particularly in rural, regional and remote Australia. So what tips have you got in that regard, Liz? If you had to triage in an AOD context and refer, what are the things that you would be looking for in that context, do you think?
Thanks, Mel. Well, of course, it becomes much more difficult in adulthood because it's much more difficult to confirm the prenatal alcohol exposure. However, sometimes that information will be accessible, particularly for people who've been taken into care because their parents have not been able to look after them because of alcohol and other drug problems. So that's a really red flag to look to get some sense of what the family background of that now adolescent or adult might be. And then to just ask the questions that might indicate that that person has difficulty with thinking. How did they get on at school? What are their social networks like? Are they able to live independently? Can they work independently? All those sort of red flags should come to your attention and suggest that maybe that person could be referred for perhaps a review by a clinical or a neuropsychologist. The other point I think that I wanted to make is that many people with fetal alcohol spectrum disorder will also experience problems with mental health disorders. And this might be anything from autism spectrum disorder to ADHD, attention hyperactivity disorder, through to major depression, anxiety, obsessional compulsive disorder. So again, they're sort of red flags, and it's always worth seeking an assessment from a psychiatrist and potentially treating those abnormalities or those challenges as well as part of your assessment. So look for a history of exposure, look at the family history, look at the medical or justice records when you've got them. Be alert to all the range of challenges that people with FASD might have, and refer to a psychiatrist or a psychologist for an assessment if you're concerned about this diagnosis. At the end of the day, in adults with alcohol and drug problems, you may never be able to absolutely confirm that diagnosis. However, any assessments will be helpful to that individual because it may lead to a range of treatments or to access to NDIS and other services.
Thanks, Liz. And just to reiterate, you can contact NOFASD Australia if you're having trouble knowing where to refer. But yes, we do acknowledge that there is further work to be done on enhancing the accessibility of assessment and diagnosis services around Australia. But there are things that you can do in the meantime to adapt your practice while you try and seek a referral for someone that might facilitate their access to NDIS or facilitate more support around transition to community. James, I might throw to you just in terms of how this is framed in terms of the module. Simone, you might need to help James out, but just in terms of the content in the module, how do we talk about incorporating looking for those red flags in existing intake assessments for the AOD sector and that sort of stuff?
Thanks, Bill. Well, I think that, I covered a little bit of this in the case study that I read out. In the module, we've included a really nice, very simple guide that NOFASD Australia has put together. And I think that covers off on some of those domains that Liz just touched on there around the family history, the sort of educational challenges, reviewing court documents or any other things that might come along with a client to when they first come into the service. So I think the first part is looking probably at that handout, and then thinking about a service's own intake processes and screening processes, and going through those whatever process you might have within your service, about how you might be able to embed some of those questions into your existing screening or intake forms or whatever process you might be using there. So I think it's just about using that handout, considering your own service, having that discussion with, through whatever governance structures or clinical governance structures you might be having, and then trying to embed that, those simple questions and simple, observations into your intake and screening processes.
Do you want to add to that briefly, Simone?
Yeah, it's pretty much what James said, but also just to remember that, if diagnosis isn't possible, just, taking on some of those adjustments and accommodations and putting them in place can really, really help and support those individuals. And also maybe other services that might be supportive, like, if there's mental health issues or things like that, getting them in contact with those services can really support them in the interim or while they don't have a particular formal diagnosis.
Thanks, Simone. And Sophie sent me a couple of hints here in our chat. The FASD Hub has a services directory of FASD-informed clinicians. And yes, NOFASD Australia via our helpline can also provide information on FASD-informed clinicians and diagnostic clinics throughout the country. So that's when you need to phone a friend, that is where you go. And Liz has also said to me that it's important to make a comment about mental health disorders in FASD. And I think in talking about that as well and elaborating on what Simone just said, it may be that the person you're looking at has other diagnoses that indicate FASD. So epilepsy is another tell, an ADHD diagnosis is another tell. There are a range of things, mental health diagnoses are another tell sometimes. There are a range of things that are symptomatic of FASD. So it may be that your person has got a diagnosis, just not a FASD diagnosis. Liz, is that a fair comment? Is there anything crucial that I've missed in that?
No, I mean, I think I touched on it in an earlier question, Mel, that this condition may present with a whole range of physical, as has been pointed out, and mental health challenges. And it's really important to refer, when possible, to an appropriate specialist to get a proper assessment done and understand exactly the person you're dealing with, because that will impact so much on how you're going to be able to help them deal with their alcohol and drug problem.
Rightio, well, we're getting close to wrap up time, and I think I'm going to give the last word to you, Steph. I'm going to throw a difficult one at you, and this is something that I really don't think that you can answer, but I would like to hear your thoughts on, in particular, given the position that you're in the NT at the moment and some of the challenges that you're facing up there in terms of service delivery and broader legislative environments, I think. And I know in reflecting on the recent coroner's report from the NT on the terribly tragic death of Melanie Walker, a lot was made of the policing response, and as well it should be, but that was a very long report. And if you look at chapter 2 of that report, I think there's some stuff that's very instructive in terms of our sector and in terms of those needs for linkage between services. It goes to the points that have been made around how important structure is for people with FASD, and how people with FASD respond really well in residential programs with structure. But it also speaks to the challenges around appropriate housing and the need for transition to community to be adequately supported for people who are either leaving custodial settings or AOD resi settings or both. What are your thoughts on that, and what more needs to happen in this space? Because as I've said a couple of times now, we can do what we can in the alcohol and other drug sector service delivery space, but it's really those joiny bits around transition to community that are really crucial in supporting positive outcomes moving forward. What would you like to say to that, keeping in mind that we have a lot of government and policy people watching us today as well?
Thanks, Mel. Look, that's a really big question. I think in the NT, we face unique service delivery challenges like anyone else, and particularly, Jill would know this from Wanada, in remote areas of the Kimberley and WA, that, the distance, workforce shortages, fragmented systems make it really hard for people with FASD to get that consistent support. So, I want to acknowledge, the coroner's report into that death of Melanie Walker and the broader concerns about policing responses. I think, this just highlights how high the stakes are when disability and trauma aren't properly recognised or supported. For people with FASD, structure is absolutely essential, as, we've heard so many people say. And I guess, Mel, residential programs, that have those daily routines and predictable environments work well. We all know that, but it can't stop there. We need to have a look at transition back into housing, and community needs to carry that same level of support and stability. Otherwise, people quickly lose the progress that they've made. I guess the views is that what's needed now is investment in joined up wraparound responses. So having housing, AOD, disability, mental health, justice services working together, and a real commitment from government to act on what we already know from coroner's reports, inquiries, and community voices, that we need to have a system that's built on recognising FASD as a disability and respond with support and not punishment. And, for, education out in the police force, education out in corrections, and education in the wider community around raising awareness and people being able to do these modules is going to be a real step into the right direction.
Thanks, Steph. I think that's really nicely wrapped up. Now, just before we finish, I would like to point out to everyone that in terms of housekeeping going forward, we have popped into the chat a link to a survey in relation to this event. We'd really appreciate you doing that. And we'd also be interested to hear further feedback around what topics you would like to see us to cover going forward. I note that there are a number of questions that we didn't get to in the quick Q&A today. There's been particular mention made of the overrepresentation of people with other disabilities, including the deaf community, in terms of people accessing AOD services, and overrepresentation of FASD. We've also talked about, in the chat here, there's some questions around the need for diagnosis in sentencing in the criminal justice system to impact sentencing outcomes and diversion outcomes for people who are coming before the courts. And the relevance of all of these lessons in terms of child protection and in terms of working with families of people with FASD around their particular vulnerability to substance use, negative outcomes from alcohol and other drug use and substance use. So we've really just started to unpack some of this stuff. And, from our perspective, and I know NOFASD Australia's perspective, we developed this model, which is basically adapted from the Canadian one, in the absence of there being anything else, and in the absence of there being dedicated funding for us to create anything specific for the AOD context. But I think the fact that we've had over 500 people register to attend this event tells you that there's a great demand for more learning in this space across the AOD sector, but also across adjacent sectors that we're working with. And as Steph so articulately pointed out, the connectedness of things is what's going to lead to more positive outcomes moving forward. And those transition to community pieces and how we can link people to the NDIS, how we can link them with supported accommodation and housing when they're transitioning from either AOD contexts or custodial contexts, are going to be really pivotal to maintaining the kind of positive outcomes that we're wanting to achieve in the AOD sector. So if you would like to fill out our survey and let us know if you have enjoyed today's event and if you have learnt anything, but also if you've got any ideas on what things you'd like to hear more about or what other ways we can assist you in your service delivery work moving forward, that would be really good too. So thank you everyone. Thank you to our panellists. And we're sorry that we're not able to pay you a lucrative fee for participating and sharing your wisdom today, but we really appreciate your goodwill. We appreciate the time of the reference group members who put so much work into supporting us in the development of this module, and we really hope that as many of you as possible will have a look at the module and do hopefully all of it, but some of it, if not all of it. And if you could give us a hand in getting the word out there to people in our sector, in adjacent sectors, around this module being available, I think that'll be really helpful too. We'll do what we can in the absence of dedicated funding, but we're really leaning on you guys out there in the audience to help us get the message out there and to provide access to this tool for people working in sectors who really need it. So thank you everyone for joining us today. We have been recording this event and we will be popping a recording on the AADC website. And if you have registered for this event, we will send you the link to that when it goes up. So that way you can flick it to other people if you think there are other of your colleagues who weren't able to attend today who might get something out of it as well. So thank you so much. Thank you to you guys for coming with us on this journey, and thank you in particular to NOFASD Australia for partnering with us in developing this module. So go well, and thank you for joining us today. Have a great day. See ya.
Mel.